Good evening, everybody, and thank you for being here. My name is Francisco J. Guerra Jr. I'm a family nurse practitioner and clinic director. I own my own practice here in El Paso, Texas, here with my wife. And thank you for joining us tonight on our call. Tonight's call is called A Needed Prescription. My background is in family medicine, and my story started many, many years ago. I like to say I was born into family medicine. My father was a pharmacist when I was born, went back to school, became an emergency room physician and a family physician. When I got out of school, I became a clinic director, a practice director, and not only did I see patients, what I was also charged with the responsibility of improving patient outcomes. So as a practice director, you're always looking at outcomes compared to other populations and your peers, and we were doing very, very well. But I was always looking to improve that. And part of why I'm talking to you tonight is I came across something that helped me with my patient outcomes dramatically, and I started using that for my own personal health first, and my patients noticed a dramatic change in myself. They kind of demanded to know what I was doing, and then I shared that with them, and they had dramatic results, and people started talking, and I started presenting cases. And fast forward a few years, and here I am presenting this webinar to you. So with that, the title of our talk is A Needed RX. It's an interventional approach to dyslipidemia, cardiovascular disease, and metabolic disease, obesity, and diabetes, and I'll include some of my case studies. And a little bit of a disclaimer: the purpose of this webinar and call is to share relevant information for those looking to improve the health of their patients, the community, or themselves. When we look at a case study, for example, for the Centers of Disease Control, who keeps statistics on the United States, and we look at obesity trends among U.S. adults. In 1990, we had a less than 10 or a 10 to 14% obesity rate. Fast forward 10 very, very short years, and now we are at 15 to 19% obesity, and even hitting 20%. Fast forward 10 short years after that, and we are at now 25, 30%, and exceeding 30% in some places obesity rate throughout the nation. That is staggering. Such a quick change in evolutionary time, but such a significant one. And so the question then becomes, why, despite all the prescription medications being used, are obesity, diabetes, and cardiovascular disease still increasing? And, that's something to think about. But the answer is very, very simple, because these are not addressing the true root of the problem. And when we continue to do the same thing over and over again and get this better results, we need to understand that this itself is a vicious cycle. So why is this important? Well, the cost of healthcare is staggering, but the real cost is unacceptable. The real cost is human lives. The cost is to our loved ones, our family, our friends, fathers, brothers, uncles, grandparents, children, co-workers, people that are not here anymore because we didn't do a better job, because we haven't turned back the tide of this cardiovascular disease. We haven't effectively had better outcomes. And so, how are we going to truly solve these problems? Well, that's what we're talking about tonight. And we need to understand one fundamental thing. And if we understand that, then this is very powerful and we can start to solve this problem. That is this: that no amount of medication in the world will ever solve essentially what is a nutritional and dietary problem. And if we understand that this doesn't solve that, in other words, medication doesn't solve nutrition, then we can start to create solutions that work. One other cycle that I want to cover, and it's very important to understand when we're looking at overweight, obesity, and that's the effect on a hormone called leptin. And when we look at leptin, we go, what is leptin? Leptin is a hormone that's responsible for satiety, or how full we feel when we're eating. So if we're not getting the signal that we feel full when we're eating, guess what? That's going to lead to overeating, to cravings, and weight gain, and that's going to lead to a lot of the other cycles that we just saw. So what causes this leptin resistance? Well, in particular, one thing here that we need to look at is dyslipidemia. And when we look at dyslipidemia or abnormal cholesterols, what we need to look at carefully is the effect of high triglycerides on leptin. And leptin, the high triglycerides will block the leptin signal, leptin hormone, from crossing the blood-brain barrier. Therefore, if you're not going to get the signal that you're full when you're eating, we're going to overeat, we're going to get obese, and we're going to have more cardiovascular and diabetes problems. But the effect again is the sum effect. Again, cardiovascular disease is the leading cause of death worldwide. So when we look at, well, where do we focus? We need to understand this. This is how I like to look at it. Improper nutrition, the diet that we're seeing today, these high glycemic foods and low fiber foods, I'm going to emphasize low fiber, this has the same effect in every individual, whether you're healthy or already have some cardiometabolic disease of some sort. It has the effect of an increased insulin response, an increased body mass index, and an increased dyslipidemic state, which leads to these syndromes of insulin resistance, leptin resistance, hyperglycemia, which all cause one thing, inflammation. And I like to describe inflammation to my patients as irritation. Imagine scratching your skin a couple times, and now imagine scratching it a few thousand times, and you'll see what I'm talking about when we say inflammation. So think of that inside the arteries of the body, and you can kind of get an idea of the type of damage that inflammation does in the body. Well, inflammation is what is the culprit in cardiovascular disease, diabetes, dyslipidemia, and cancer. They cause all the harm that lead to mortality. So today in medicine, we focus our pharmacotherapies here heavily on cardiovascular disease, diabetes, dyslipidemia, and cancer in an effort to delay or avoid complications or delay premature mortality. But what I'm saying is that we need to focus here on improper nutrition and avoid this entire progression of disease altogether. So what I'm really saying is the solution is to prescribe nutrition. Now, I'm not talking about any old nutrition. I'm talking about something called medical nutrition. And when we look at what is medical nutrition, we define that. I'd like to look at the guidelines first, the NCP-ATP3 conference guidelines authored by the National Institute of Health. These guidelines have been around for quite some time, and this was the gold standard in treating dyslipidemia. Now, what I will tell you is what was listed in the guidelines and what was commonly practiced are two different things. And so we tend to think of the guidelines as what medications to write, but what I'd like to share with you is what's actually in the guidelines. And when we look at the first page of the guidelines, it's all about assessing risk until we get to the bottom of the second page. And at the second page, we actually see the first step of therapy. And the first step of therapy is not a drug. It is a formula. It is something called TLC diet. It's called Therapeutic Lifestyle Change diet. And this is a formula that is less than 7% of calories from saturated fat, less than 200 milligrams of cholesterol a day. And right there, a patient that I was explaining this today to said, I wouldn't know how to do that. And I said, I completely understand. So what I do is I try to break this formula up into two pieces that are easily understood. It's an effort to limit the bad, which is less than 7% of calories from saturated fat and less than 200 milligrams of cholesterol a day. And unless you're going to weigh and measure your food and then make some calculations, this is probably impractical information. So it may be accurate, but it's impractical. So what I focus on in my practice is the second part, which is adding 10 to 25 grams of highly viscous soluble fiber and 2 grams of plant sterols or stanols. Now, when we look further in the guidelines, the next page, above all the medications, it says consider adding drug therapy if LDL levels are still high or bad cholesterol. And what this really means is it's clearly indicating that drug therapy should only be added after this TLC diet formula that is step one. So with that said, we look at one other set of guidelines, the ACE guidelines, American Association of Clinical Endocrinologists, and what do they say about the management of dyslipidemia and prevention of atherosclerosis? Well, very simple. They recommend a comprehensive strategy to control lipid levels and metabolic abnormalities, and then they go on to say the first line approach to primary prevention patients with lipid disorders involves implementation of lifestyle changes, including physical activity and medical nutrition therapy. So here we see this term defined. And within this term, you're going to see the ingredients of 10 to 25 grams of highly viscous soluble fiber and 2 grams of plant sterols. Again, this is a grade A recommendation, the highest level recommendation based on the research available. So when we look at articles that continue to come out on studies of dietary fiber, here is a recent article from JAMA Network in 2011 published called Dietary Fiber Intake and Mortality in the National Institute of Health and American Association of Retired Persons Diet and Health Study. And this was a huge study with almost 400,000 men and women ages 50 to 71 across the United States. And it was a special study approved by the Special Studies Institute Review Board of the U.S. National Cancer Institute. And this is a very good study. The appropriate variables were controlled for, is very strong. And when all the variables were controlled for, what were the outcomes? The outcomes were amazing. The outcomes of this study showed that higher dietary fiber intake resulted in a 24 to 56% lower risk of death in men and a 34 to 59% lower risk of death in women, not just from cardiovascular disease as we would expect to see, but also from cancers, infectious, and even respiratory diseases. Why? Well, we know why. Because fibers and plant sterols naturally detoxify the body. And when we reduce inflammation, we reduce the damage of not just cardiovascular disease, which is an inflammatory disease, but other inflammatory diseases. So my question then to you is, if we know what's needed, what is the problem? And here's the problem. The problem is the latest recommendations to acquire, or the latest recommendations are 9 servings of fruits and vegetables. And hence the problem. Because the average is 3 servings per day. I realized before the webinar, I was thinking about my day, and I said, wow, I've had 1 serving of fruits and vegetables today. Technically, I've had 1. So the likelihood that I'm going to go home and eat 8 portions of fruits and vegetables is very unlikely. So I supplement my diet, and because I know these guidelines and I know the information, and I want to reduce my risks. Now, here's the real problem. We're just not getting the fiber or phytonutrients needed to control dyslipidemia per the guidelines that I just showed you. The resulting hyperinsulinemia and overweight, and the resulting overweight and obesity, and that I'm going to explain right now. So the solution then is just to look at this existing problem and to prescribe the medical nutrition that's indicated in the guidelines, just like we prescribe prescription drugs. But here's the catch: in a manner that's easily incorporated. Because we can make posters that say exercise daily. We can also make posters that say 9 portions of fruits and vegetables a day. They're going to work just as well as exercise daily, right? And we can have the best intent, but I know this information, and yet I was only able to get 1 serving of fruits and vegetables. I was able to send my medical assistant to go get me something to eat, probably around 3 or 4, when I realized that I wasn't going to get a chance to go home, much less break, because I was so busy seeing patients. And guess what? That's a lot of our days. And you don't have to be in the medical field to have that kind of a day. So we need to engineer solutions, and we need to empower people with systems and tools. And people, because I'm in a practice that provides wellness advice, and we use nutritional tools, people ask me, what do we use? As a consultant, as somebody that's recommending this all the time, that talks on this, they said, what do you use in your office? And I said, what I use personally is what I use in my office. And they said, well, what do you use personally? And I said, what I use with my patients is something called Unicity Balance. And Unicity Balance is a fiber nutrient, a non-pharmaceutical fiber nutrient drink. It comes in a packet like this. You mix it with water, shake it up. But what is this? This is a 5 highly viscous soluble fibers into 2 grams of plant sterols that I just showed you were called for in the guideline as first-line therapy for treating dyslipidemia. And remember, cardiovascular disease, #1 cause of death worldwide. So what I tell my patients to do is take 2 of these packets, 1 before each meal, 2, and you get your 2 grams of plant sterols or stanols that are called for in the guidelines. Now, what does this do? Essentially, this is nutrition with proven clinical benefits, and it's addressing lots of needs in medicine today. So let me explain the mechanism of action. So I'm going to talk about just this one product, the Unicity Balance formulation, for the sake of time. And I'm going to go over 3 quick mechanisms of action. The first one is very simple. We just spent some time going over dyslipidemia therapy guidelines, and when we address dyslipidemia, in particular high triglycerides, what are we doing? We're restoring leptin sensitivity. When we do that, we're providing the reduction of cravings, and we're causing earlier satiety in the meal, so we're really getting portion control. The second mechanism of action, very simple, it's mechanical. When you take highly viscous soluble fibers and you mix them with water, they thicken and they gel. And we want that effect in the stomach prior to eating because it's going to give people a sense of satiety before they start eating, a sense of fullness. And that's important because people are still going to eat what people are going to eat. So if we can reduce portion size, caloric intake with tools like this is very valuable. But the third mechanism of action is probably the most important and most powerful to me because I treat a lot of cardiovascular disease, dyslipidemia, and diabetes. And that's when you put this product before food, what you're doing is you're delaying the absorption of glucose and therefore modifying the rise of insulin. And this is the way I'll explain it. When you take the standard American diet, the acronym is SAD, the SAD diet, which is this high glycemic food, low and highly viscous soluble fiber, and this type of food, glucose rises and drops very rapidly. Insulin rises with glucose, but insulin decreases slower. However, when glucose is dropping, what is the effect that a person feels? They feel hungry, they feel fatigued, they feel shaky, they feel irritable, they get a headache. The result is they reach for something else similar and they repeat the pattern throughout the day. So insulin never gets a chance to really come down, and this is extremely important because high insulin, excess insulin, causes weight gain and inflammation. So what I do is I tell my patients to take this before a meal, and what we're really 10 to 15 minutes before a meal, they put it with water, shake it, drink it 10 to 15 minutes before they're going to eat, and then what does that do? That actually suppresses the rise of glucose, and therefore we're able to control the rise of insulin. And when we use appropriate meal spacing of 4 or more hours, what we're actually doing is creating a presence of low insulin in several points of the day. And this is very important because in the absence of insulin or the presence of low insulin, the body is actually able to burn its own body fat for fuel. So something that would obviously be very important with the excess body weight that we're seeing today in all our populations. So there are some other mechanisms of action that are very powerful and that are very significant: polycosmal, chrysanthemum, calcium, B vitamins, multiple minerals. Too much to really go over tonight, but what I will share with you is this. What impressed me when I first did my research on this product was the effects of this balance formula on cardiovascular disease were clinically established. And when I say that, this product was created at Stanford School of Medicine in 1990. Since then, there have been published studies from the University of Connecticut, Emory University, Columbia University, UCLA, and double-blind placebo-controlled studies, 8 published clinical studies in peer-reviewed journals. And the product is in the physician's desk reference. So what were the results of those studies? Well, in the patient outcome data, what we saw with monotherapy, the Balance product alone, was a reduction of LDL 31%, and a reduction of bad cholesterol 31%, while raising the good cholesterol HDL by 29%. That was simply with monotherapy. When we added this to people that were already taking a statin drug, we were able to see an additional 20% lowering of LDL. Now, when we looked at postprandial glucose peaks, and I've already alluded to this mechanism of action, when we were able to suppress the peaks after eating, and we added that up, the net effect of that over 90 days, the effect on the hemoglobin A1C was profound. And it was in the patient outcome studies, we were able to see a reduction of hemoglobin A1C by 15.2%. Now, if you understand how significant this is, and you treat diabetes like I do, you understood. I saw this in this data and I said, if this product only did that, that's all I would need it to do. But the side effect was multiples. The side benefit, I should say, whether it was postprandial blood glucose, average fasting blood glucose, total cholesterol, hemoglobin A1C, blood pressure, body weight, triglycerides, or HDL, everything moved in the direction we wanted to see resulting in an 18% reduction in macrovascular endpoints. So that's why healthcare providers like myself are recommending these products to our patients, safe even for children. And why do I say that? We have childhood obesity problems, and I really like this product. I'm really grateful to the company for coming out with a pink lemonade flavor because we have to be very careful with our children. They have body image issues. There's bullying. There's all kinds of things. And when we see them as overweight or obese, and we see them with high blood pressure, or we see them with high cholesterol or high sugar, the last thing we want to do is create body image problems or create low self-esteem. So instead of telling somebody, here, this is something that's going to help you lose weight, what I tell them is this is a pink lemonade that is going to help you with your cholesterol or help you with energy, et cetera, something positive, and actually enjoy drinking it. And I absolutely love this. I drink this unnecessarily too frequently throughout the day just because I like the flavor. So this is something that definitely relates to kids. This kid likes it too. So, but like I said, there's a purpose for this. It's not just fun. It's serious science, and we have serious problems and we need to address them. And this is safe for use with medication. This is a food-based product. And when I say that, if somebody has dietary restrictions, what are the dietary restrictions? Is it plant sterols, stanols? Is it fibers? So there's very few contraindications. If your medicine says take on an empty stomach, we'll separate this product from your medicine by at least 2 hours. So it's meeting a need today in my practice. A word of caution, when I say it's safe for use with medication, I will say this, and I always say this, for people that are on insulin, just a word of caution, it works the very first day you start to take it. You can expect a drop in your glucose, and therefore you can expect a drop in your insulin requirements the very first day. So you need to, if you're on insulin, you need to know how to scale back your insulin when you start taking this product because it will work. That's not by accident. The company that makes this is Unicity International. It's a science-based company. Actually has its origins in the pharmaceutical industry as Rexall Pharmaceuticals or Rexall Drug Stores. And it's a successful company. What I like to say is 22 years ago, they took a right turn into wellness, and they fostered relationships with leading research institutes, done lots of research and studies, so much so that they have 11 products in the physician's desk reference to date. True testimony of how hard they've worked on that. It's helping healthcare providers in multiple specialties, whether it's myself in family practice, my wife in women's health, cardiologists, the wealth of cardiologists. I was so grateful to Dr. Oscar Aguilar, El Paso, Texas, interventional cardiologist, who referred this product to me just for my personal health and also to educate me that he was going to be using it in his patient population. And as he told me, the results that he was seeing, he told me where he learned about it from another interventional cardiologist that he trained with at Baylor College of Medicine, Dr. Laura Fernandez, who found out about it from another cardiologist, Dr. Annie Varghese, and who found out it from a registered dietitian. And we share this information with our colleagues because we care about them. And by default, what we need to understand is every patient still sitting in our waiting room in metabolic disease, overweight, or obesity have situations that they either do not know how to control or have been unable to correct thus far. And sometimes my patients say, yeah, I know I need to lose weight. And I said, okay, you don't want to? No, I want to. I said, okay, you don't know what to do. No, I know what to do. And I said, exactly. And they said, what do you mean? And I said, whatever you've been able to do is because of what you've been able to do or what you know. And so we need to help each other. We need to help one another because if your patient has metabolic disease, overweight, or obesity, they haven't been able to get the job done. So we need systems and tools that can. And the problem that as healthcare providers is that we just need to recommend the medical nutrition that's indicated in the guidelines. Now, here's the problem in healthcare. Most healthcare providers don't have the time or resources to do one more thing. And because of that, I'm very grateful this company's developed not only products, they've evolved products, but they've evolved systems and tools and programs. And so I'm very grateful to this company for creating this because it saved me a lot of time and it's helped my patients tremendously. This company knows that these products really need to be first line in the medical field. And what we need to understand is systems work and people fail. In the immortal words of Albert Einstein, doing the same thing over and over again and expecting different results is insanity. So when to prescribe medical nutrition? Well, you know, you can count many, many reasons. This is an incomplete list, but here's a short list. Dyslipidemia, cardiovascular disease, metabolic disease, abnormal glucose, hypertension, prehypertension, diabetes, prediabetes, PCOS, polycystic ovarian syndrome, dietary deficiencies, when people desire weight loss, for people that are overweight, for people that are obese, postpartum weight loss, for inflammatory disease, people are irritable bowel syndrome, hypoglycemia, because low blood sugar comes from high blood sugar dropping, a fatty liver, elevated liver enzymes, people that are looking for non-pharmaceutical or non-prescription drug alternatives, for people that can't exercise because of back pain, knee pain, hip pain. So many people say, oh, I can't lose weight because I can't exercise. And I said, you can lose weight through nutrition. It's actually more predictive of you losing weight than exercise. And for pediatric populations, for people that are health conscious, it's preventive medicine, it's part of the solution, it's part of a cure. So, per the guidelines though, in summary, medical nutrition and lifestyle modifications are always first-line treatment, period. And, I've given you a couple solutions and tools and options that you can use in your patients. Let me show you what happens, or what's happened when I simply started instituting this into my practice. Case one, this is a recent case. I'll call it, how much medication do you want? And this is a very non-motivated patient. These are not extraordinary results. I'm going to show you a very poor result by a very poorly motivated patient. Is my first case study. And what I'll say is, this is a 69-year-old female, body mass index of 32. She has diabetes, she has hypertension, but what I really want to focus on is dyslipidemia, or high cholesterol, because I want to focus on the fact that she's on the highest dose of the cholesterol medicine permitted by law. As a matter of fact, there's a black box warning at half this prescription. So at 40 milligrams of the statin drug, there's a black box warning saying, additional cause of death or risk, and she's at 80. And here are her results. All of her cholesterols are out of range. All of them are elevated. Her blood sugar is elevated. All of her cholesterol. I said, this is a dietary problem. This is not a medication problem. This is more than enough medication, and we're still not controlling things. So I called her in the office, and I said, you know what? Let me show you what's indicated. And I went over the guidelines, and I said, do you really want more medication with the risks of the possible risk of combination of cholesterol drugs? And she, basically said, no, I really like to try this nutritional option that you just told me about. And I said, okay, great. And I said, let's recheck your cholesterols in 90 days. And she goes, I don't want to wait 90 days. I just want to wait 2 months. I said, well, let's give it 90 days to show an effect. And she says, no, and she insisted on 60 days. And 60 days later, here we are. We've already reduced almost every cholesterol has improved into normal range. And her blood sugar has dropped over 50 points. And, at this point, I called her. I said, what changed? I told my medical assistant, verify that she's taking the product. I want to make sure that this is what we're responsible. And she says, yes, she's taking the Balance product. So, with this, a very highly unmotivated patient, all they did was add taking this product to their diet, and their lipids improved, their glucose improved, their appetite improved. And we did it without more medication, more risk, because in this patient's case, it would have been very risky to add more medication because she was on a multitude of medications. So case two is something I call a 2 routine physical. And this is a case of a patient named George, 56 years of age. He's just there for lab work. He just wants a lab order. And I said, what about your medical history? I goes, I don't have any. There's nothing wrong with me. I don't see doctors. And I said, okay, well, how about family medical history? He's like, my parents aren't alive. I don't have, and he just really didn't want to talk about it. He just wanted that lab order. And I was like, and then he finally said, look, I'll get a discount on my health insurance if I get this lab work done. I said, okay, George, let's get the lab work done for you. I'm going to do a quick physical. We'll get the lab work done. Well, here's the initial intake. Here he is at 207 pounds. And here's his initial labs. These are his initial results. And his fasting sugar is 166. 166, okay? So just for reference, in the U.S. system, fasting sugar of 125 or greater on 2 occasions is diabetes. Hemoglobin A1C of 6.5 or greater is diabetes. And he is at 166. Well, I call him in the office and I say, I need to get that hemoglobin A1C. He comes out at a 7. So here he is at a fasting sugar that's clearly consistent with diabetes and a hemoglobin A1C that's clearly consistent with diabetes. And I told him, I said, George, listen, anybody else's office, you're going to end up on medication. But I happen to know about a medical nutrition and an option, a medicine nutrition, I mean, excuse me, a nutritional option that will help you. And he said, you know, what do I have to lose? And I said, well, let's find out. So he decided to do a 90-day trial. Why? Because the product is guaranteed for 90 days. And he said, okay, let's give it a try. And this is his follow-up. 45 pounds later, he had, or I should say, 3 months later, he's down 45 pounds. And, that he was, thrilled about. But this I was thrilled about, which was his hemoglobin A1C went from 7 to 5.4. So we essentially took somebody that was consistent with diabetes and made them consistent with normal. So, and that was just in 4 months without adding any pharmaceutical medication. So, case number 3, what about somebody that's already an uncontrolled diabetic and has uncontrolled dyslipidemia? Well, this is the case of Mrs. M, 45 years of age. She's in for a routine diabetic follow-up, non-insulin dependent diabetes, uncontrolled on multiple oral diabetic medications. Here's her lab work, and we can see that her HDL is low, her triglycerides are high. Her fasting sugar is 222. Her hemoglobin A1C is at 10.8, and as we know, and as I wrote on her labs, above 8 on multi-drug therapy, above 8, she's supposed to be on insulin. So I'm not very proud of the fact that one of my patients was at 10.8. As a matter of fact, when she was in 8.7, I told her we really need to do medical nutrition, and she said, no, I'm just going to try harder on her own. Well, she got herself worse. So at this point, I said, listen, I can give you an additional oral medication. It's not going to get you to goal. I can put you on insulin, which the guidelines say to do, or I can recommend an appropriate nutritional supplement that will actually, something that you're missing in the diet to help you control your appetite and your blood sugars and your insulin response to food. And she said, okay. And she decided to do that for a 90-day trial. She was very happy that it had a 90-day guarantee. And she was more happy, and so was I, about her results. Now, all of her cholesterol is normalized. Even her LDL dropped to 77. Her fasting blood sugar dropped from 222 to 106, and her hemoglobin A1C dropped from 10.8 to 6.8 in just a little over 3 months. I'd say less than 4 months, just by adding the nutritional supplement. So that's the power of what can happen here. Case 4, I'm going to, we're running late on time. Let me try to get this case and maybe one other case, but let's at least get this case in. And this is somebody that's referred by a friend for uncontrolled diabetes. Now, when somebody is referred by a friend, that means that wherever they're receiving their health care, they're not getting help. And, lots of healthcare providers mean well, and they're probably, writing all the right medications. So what can I do different? Well, I have another arsenal in my tool chest. I use medical nutrition. So when this person was referred to me, first of all, they're expecting a miracle. The friend is. And I always want to deliver. So I'm going to give this patient every bit of attention that I can. I'm going to try to pull off what somebody else hasn't been able to pull off. And so this is a case of Mrs. L, and she's a 54-year-old female, beautiful woman, 192 pounds, normal tensive, body mass index of 35.5. She's in for uncontrolled diabetes. Here's her medication list. She's on Crestor and Trilipix, 2 brand name, basically lipid medicines, in maximum doses of 3 diabetic medications, maximum doses in metformin, glipizide, and Byetta, one being an injectable medication. And nevertheless, her hemoglobin A1C is 10.9. Now, for reference, diabetic goal is 6 to 6.5. Now, this is when I saw her in November. She's at 192 pounds. Her hemoglobin A1C, I wrote on her labs above 8, insulin's recommended. Of course, I don't want to put her on insulin. I know that there's better options out there. So I talked to her about, her options, and I included insulin or this money-back 13-week coaching program called the Transformation. And when she asked me about it, and I told her, well, we're going to give you nutritional teaching, guidance, fitness, she said, that's what I want. That's what I want. I want somebody to help me. I want somebody to teach me what I want to know, what I need to do. I need that. I need that kind of support. And so she thought this was invaluable. She said, I didn't even know there were things like this. And I said, yes. And I said, and by the way, it's 100% money back guaranteed. And she says, how do I get it? And so I helped her start on the program. And I said, listen, from a medical standpoint, all I want you to do is monitor your blood glucose and see me in a couple of weeks. And so that's what she did. And at that point, I was able to stop one of her medications. This is a glucose log. And I stopped one of her medications. And then as I was confident that she was doing well, I just put her on autopilot. And I said, you know what, I'm going to see you at the conclusion of your program. And so here's somebody that's uncontrolled. I see her once, initial eval. I see her 2 weeks in to check her blood sugar. And then I release her to the program. I say, I'll see you at the end of the program, and we'll repeat your labs. So when I saw her back, she was thrilled. First of all, she was down 18 full pounds. Want to make a woman happy, help them lose 18 pounds. And so she was ecstatic, but want to make a healthcare provider happy, you can see that her results, her triglycerides, remember she was on 2 brand name lipid medicines. Nevertheless, her triglycerides were 310. Remember what I said, triglycerides, leptin resistance, appetite, cravings, hunger? Well, we were able to cut those down to in half to 173. We were able to drop her fasting sugar from 278 to 167. And we were able to drop her hemoglobin A1C from 10.9 to 7.3 in just 13 weeks. And this was, we were just getting started. So we did this without adding any medications. As a matter of fact, I stopped one of her medicines